Thank you, Dr. Mullick. That was a wonderful, wonderful talk. Can't wait to get to the Q&A to ask you some questions. It's my pleasure to now introduce Dr. Christopher Deible. He's an assistant professor of radiology in the Division of Thoracic Imaging here in the Department of Radiology, University of Pittsburgh. He'll be speaking to us about advanced imaging for thoracic aortic disease.
Yeah, hey, it's a pleasure to be here and my honor to talk to you guys today. We're going to talk about imaging for the next 15 minutes. We're going to start off with what I think is, pretty much the standard of care around thoracic aortic imaging, and then move into some, more cutting edge things and problem solving processes that can be used. So thoracic imaging really, runs the gamut of the care cycle that you're going to hear about and are hearing about today, from diagnosis, stratification. I think it's really fascinating to look at some of the genetic data that's coming out, and you can see this stuff on the images. I have some slides coming up. Timing of surgery is, essential, and operative planning and post-op imaging are all things I'll touch on. And really, one of the keys to successful imaging is to make sure that the imaging team is actually aware of, what the plan is and, what the thought process is clinically. We actually have, we put a tremendous amount of effort in our area into lab techs, 3D lab techs, and they actually go out and look at every single case. We see the scripts, but often the information doesn't really come off or come through clear enough on the orders and things like that. So really is essential to kind of collaborate closely with the imaging department and make sure that that information is getting passed along. So to start off, the basic aortic CT protocol, for us, we use contrast-enhanced thin section images, angiography, and arterial phase, and every vendor that's out there is able to produce these. Generally, at the we look for minimum of 64 slices. Can produce standard of care images. Generally, if you're using lower scanners, you're probably going to run into issues with timing, being able to meet up with the standard of care. Also, the larger detector widths and dual source scanners provide additional benefit and opportunities for improvement. And talk a little bit about gating here. Gating is essential for ascending disease, not as essential for disease in the distal arch and descending thoracic aorta, and we'll go through some of the details of that. And then contrast concerns. We still do use some patient-sized based parameters to determine contrast dose and rate of enhancement, because really arterial phase enhancement is related to that rate and not the total volume. We use the right side whenever possible to avoid streak artifact and other things in the brachiocephalic area, and we do have reduced contrast protocols, which I'll talk about. So ECG gating, again, is essential for any imaging of the ascending aortic root, eliminates pulsation artifact as a consideration. That becomes essential in the ER for some of the more acute findings, but also even for accurate measurements over time, because you can basically guarantee you're getting in the same area of the cardiac cycle, same size of the aorta. And then this allows most gating systems allow reconstruction in different areas of the cardiac cycle depending on what the goals and objectives are. I put this slide together just to show you there historically there's a lot of scanners that are still working on retrospective gating, which gives radiation dose throughout the cardiac cycle with some modulation to moderate dose, but that's more of a helical scan that processes through the patient. Most of the more modern scanners are doing back to prospective gating, mean one single beat move and a single beat and move in imaging. And that allows for opportunities to minimize motion during scanning. And then on the graph here, this is sort of the ventricular filling curve. We target two specific areas, generally end systole, where there's minimal motion and isovolumic relaxation. And then in the end diastolic phase is where there's the least amount of motion in the aorta, typically for reasonable heart rates prior to the P wave. And the reason this is important is the aortic size does change. This has become very apparent with things like, aortic valve remote planning. We now, do images throughout the entire cardiac cycle for a lot of valvular disease in order to do this, but it's the aorta as well, which can change size throughout the cardiac cycle. And it can vary as much as 4 to 5 millimeters in difference. So if you're measuring just on axial non-gated images, especially in the ascending aorta, you're going to potentially get variability in those measurements. So I put this slide together rather than having a whole cine of the slide. And on axial images, you often don't appreciate it, but on this image, this was obtained in 2 separate heartbeats, the 256 320 slice CT. And you can see in the middle of the image there's some change in contrast level. That's actually where the heartbeat and different heart rate went. And on 64 slice CT, you can see a lot more of this banding that goes through the image. Generally, it doesn't affect interpretation when it's this level of artifact. But there can be larger image quality issues. Some patients have stiff shoulders. You put them in the scanner, and if you're moving in between heartbeats, they can actually move in the scanner, and it comes off as these discontinuities that you see at the top there. This protocol was done to image the chest gated, and then the abdomen and pelvis were imaged non-gated in a typical helical pattern, and then all put together. You can see this end of the second beat here where the contrast level again changes. And again, you barely notice these things on axial image, but they're much more apparent on reconstruction. And I mentioned pulsation artifact. I think most people are probably familiar with this, but it definitely can be a troublesome thing to look at images with pulsation artifact. They tend to pop up in the worst possible places and worst possible times if you're not gating, and can mimic a true aortic dissection. And generally, there are some factors that lead you towards pulsation artifact where it's affecting multiple vessels, et cetera. But if you can gate, especially in emergency care, in the root region and ascending aorta, it's definitely beneficial. And then wanted to talk a little bit about the multi 4D cine imaging. So we'll do for a lot of valvular cases and root cases, it's helpful to have, to get an idea of the morphology throughout the cardiac cycle. So this is an image, and I didn't, create movies. This is actually a 4D movie with 10 phases throughout the cardiac cycle. And you can see the bicuspid valve in diastole and then in systole with it open. And there's representative phases. So when you look at the EKG tracing here, which is from the patient during this acquisition, the gray represents when radiation dose was administered, the blue represents what was reconstruction, and the white represents those individual phases. So you can kind of get an idea of where we're reconstructing and what the images represent throughout the cardiac cycle. This is a more traditional tri-leaflet valve in diastole and systole. So a couple notes about standardized measurements. You always want to use orthogonal measurement technique. Oblique, double oblique reformats and thin multi-plane reformats are the standard. Generally, some PAC systems have this integrated, or you can get 3D post-processing packages that have that capability. Measurements off of axial images are often unsatisfactory and misleading and not reproducible. And I mentioned it before in terms of gathering clinical history. Our 3D lab is essential in helping with standardization of this process. And we wouldn't be able to, support some of the needs of the Thoracic Center without a 3D lab and that uniformity. And generally, our 3D lab will measure the standard areas of the aortic root, arch and descending thoracic aorta on every single case. Often, even on multi-plane reformats, if you're measuring without being truly orthogonal, you can make measurements, but they're often off from what standards are in terms of the three-dimensional orthogonal measurements, depending on the angulation. And being off by 2 or 3 millimeters from year to year really limits the ability to assess people for progression of disease. And on this case, I put a marker here. It's a little hard to see, but you'll see sometimes radiologists, will make measurements, across here, measuring the largest dimension. That's really inaccurate. Here I measured across here, or showed depicted measuring across. Generally, when you're looking at a large number of CT scans, there are some things over time that you can do to sort of get a gestalt of what changes are, but in terms of actually reporting and making clinical decisions, we try and make those off the orthogonal images. And then a few comments about visualization. Window width and level is really important. You can really lead to some misinterpretation, and I'm going to bounce back to this image. Noise is actually our friend. In the case of CT, you want to be able to see some of that noise when you're window width and leveling to look at studies. Calcification obviously can cause a lot of problems, streak artifact and other things. And we use volume rendering techniques to create summative information. And generally, thin section multiplane reformatting is a standard of care. MIPS and curve planar reformats can be helpful for summative information, and volume techniques, as I showed early on, are really great for a picture is worth 1,000 words in terms of what's going on with the patient and surgical planning. I mentioned we have low contrast dose protocols, and we'll image, generally our regular protocol will be somewhere between 70 and 100 cc's of contrast. We'll skinny that down to 30 to 50 cc's in patients with renal compromise. We're still using the fastest scan pitch and smart bolus tracking to make sure that we're minimizing contrast dose. We also do some imaging non-contrast, so we will actually gate the scan and image them non-contrast. The most important thing to keep an eye out for, and I put some measurements here, you really have to look at where you're measuring and potentially even re-measure other cases that may have had contrast. Because the wall thickness there can actually make a pretty significant difference. So non-contrast scans are always measuring the outside of the wall. People tend to measure the contrast lumen on contrast-enhanced studies, so just be aware if you're comparing contrast and non-contrast images to be careful about that. And we also can use MRI for surveillance, sometimes in younger patients who need long-term surveillance, some of these connective tissue disorders. It's beneficial. I'll show you some images. Obviously, you don't want contraindications. With renal issues, we have concerns with MRI, but we do use a non-contrast MRA technique that's actually pretty good. And also, MRI can help with vasculitis. In the ascending aorta protocol is basically Cine images and breath-held this is a breath-held non-contrast respiratory and EKG-gated image. And it really does provide good visualization of the entire thoracic aorta. We can get detailed measurements off of this, again, non-contrast and respiratory and EKG gated of the aortic root, and the same measurements that you can get with CT. And again, there's always some minute difference between CT and MRI in terms of potentially the phase, so you have to be careful in comparing studies longitudinally in terms of drawing too much conclusion, but from one study to the next, there's good reproducibility. And the anatomic resolution is really pretty good with these studies. You can see the coronary arteries. It's not necessarily good for reading the coronaries for stenosis, but just in terms of the actual definition of what's going on. I'll talk about acute aorta. We add non-contrast images, and this is mainly to identify calcifications and intramural hematoma. In this case, you can see the high attenuation crescent sign. A couple more cases where you can see the thickening and high attenuation material around there that's worrisome for clotted blood. And again, in the aorta here, layering posteriorly some of these things that you can see. And I mentioned earlier, EKG gating in the root is really helpful if you can manage it. It's often not necessarily possible with every single case. But these dissections that extend into the root can be difficult to determine whether or not they involve coronaries and other things that can be resolved with EKG gating. And post-op scans, again, we use non-contrast studies because there's a lot of surgical material. Incidentally, this surgical material almost always looks like contrast-enhanced blood. It's really hard to tell the difference. This one, I think everybody would know this is felt, but there are cases where it's more subtle. when you look at the non-contrast scan, you can compare and be fairly sure that you're having surgical material. This is a case that had a more complex post-surgical condition, and it looks like there's little pseudoaneurysms around and other things. In this case, those were all calcifications and surgical material. There was some contrast outside the lumen, but you can really use the non-contrast to help be more specific with interpretation and care. And then endovascular surgery, we add delays. You do have to be careful today. With reduced dose protocols and faster scanning, we are using less contrast, which limits the overall enhancement with delayed images. Delays are dependent on the volume of contrast, not the rate of administration. And so you have to be careful in using that. And, obviously we look at things like the bird beaking. In this case, we also do non-cons to differentiate potential contrast outside the lumen from calcification. You can use MRI and CT for these things to evaluate that. Obviously, we look at this. This is starting to get into some more problem-solving tools that we use or can use. Obviously, we don't want to have this thing displaced from the side wall. There are some studies showing measurement of the lumen and in systole and diastole displacement of that. MRI actually has, I showed you the cine image earlier, we're able to resolve 10 phases per beat. MRI is able to resolve 30 phases per beat, so it's a little more detailed in terms of what you can do, and we're obviously trying to avoid some complications where that stent graft can get displaced from the wall, causing severe issues. Other things that can be done, endografts can be evaluated with non-contrast CT. And one of the ways that this is done, and I'm going to skip ahead here, is actually by looking at the volume of thrombus. I think characterization this way is something that can be done in patients with severe renal issues. I did want to mention, vasculitis protocols. We use this. We do delayed imaging, so you can see CTs rather nonspecific, some periaortic fluid or tissue. You can really get a good idea of enhancement of that periaortic tissue with MRI. This is MRI before contrast and with contrast. And the benefit of gadolinium is it's much more sensitive in terms of small levels of gadolinium around. And then I'll close with a couple of quick comments about what's coming down the road. Photon counting CT is coming. It promises, hopefully lower doses, much higher spatial resolution, and much more multispectral energy. So for things like resolving calcification, some of the aortic root problems, we may get better information from photon counting CT. This is just an example image that was recently published from the first clinical scanners, showing actual stent detail as opposed to what you can do on a state-of-the-art detector scanner, not using photon counting. And really pretty impressive. The spatial or the spectral information can be used to create virtual non-contrast images. Here's a real non-contrast and a virtual non-contrast. That virtual non-contrast was created. And you can see whether it's arterial phase or portal venous phase, it works the same way. And so working to perfect this technology could potentially decrease the amount of repeated scans. And I think another exciting area is 4D flow imaging. As we look at morphology of the aorta, opportunities to look at the flow and how that interacts and affects aortic structure and aortic follow-up is a potential big area. And finally, we can do dynamic imaging within a heartbeat. We can also use dynamic images with multiple phases. So getting at endostent leaks may be a way to look at that because, with complicated endografts, it's often hard to tell where endoleaks are coming from. And I think I'm also have a role here in informatics, and I think I'm very excited about the future from an informatics perspective. Some papers published, and I think we're going to hear from Kim Eagle later on some of the aorta work they do, but just very interesting in terms of data aggregation. The world of radiology hopefully is changing. Structured data is much easier to get into reports, and hopefully leveraging this data can help us with predictive therapies, and also the world, with development of artificial intelligence therapies, which are really exploding in terms of use cases in imaging, both pre-scan and post-scan. And in conclusion, I just wanted to reemphasize, make sure that the imaging team knows the history before scanning, use MPRs for orthogonal measurements always in follow-up, and use ECG gating whenever possible for ascending disease.